Thank you for tuning in as we go over the identification of protein biomarkers in the era of precision medicine oncology. My name is Hilal Arnouk. I am a pathologist and a cancer researcher. Our objective today is to highlight the role of proteomics in precision medicine oncology and go over one approach using clinical proteomics as a tool to identify novel biomarkers. As you are fully aware, cancer is a leading cause for morbidity and mortality in developed nations like the United States. It is estimated that 1 in 2 men and 1 in 3 women will experience cancer in their lifetime. It should be mentioned that cancer mortality is slowly declining over the last few decades at a rate of about 20% over the last 2 decades. And that is due in large part to early detection of cancers, specifically before they metastasize and become incurable. In fact, early detection and prevention have been the best weapons we have against cancer since this country declared war on cancer with the signing of the National Cancer Act in 1971. Traditionally, pathologists classified cancers based on their appearance under the microscope, or what we call morphology. However, with the advancement of the fields of genomics and proteomics, specifically after the completion of the human genome sequence, we are able now to utilize these tools to look for molecular signatures for every cancer, specifically looking at the normal processes and pathways in a cell that become hijacked by the malignant cell for transformation and later on the steps of tumor progression. So in proteomics, we hope to map or profile the protein landscape of a biological sample. It could be a tissue sample or it could be a serum sample, for example. In either case, we can do expression analysis, looking for proteins that are upregulated, downregulated, or missing, or we can also look for their function, or what we call functional proteomics. Now, why do we look for protein biomarkers in specific? We like proteins because they are the functional unit in the cell. Moreover, they tend to be more diverse and complex than their cousins in the DNA or RNA. Specifically, they tend to preserve or retain all the upstream genetic information, like mutations in the DNA. They can also tell us about gene expression and epigenetic regulation of gene expression. They could also reflect processes upstream, such as alternative splicing or post-translational modification. So the example we are going over today has to do with cervical cancer. Cervical cancer is one of the most common cancers in women worldwide. I think right now it ranks as number 4. It affects about 500,000 women every year. And for about half of these patients, it turned out to be fatal. As many of you know, this is a type of cancer that starts with a viral infection, specifically with the high-risk human papilloma viruses. And over the course of a decade or so, the lesions can progress from pre-malignant into invasive carcinoma and later on into metastatic carcinoma. So because of all of that, cervical cancer is an ideal disease for screening tools, as I will show you a little later. So about 99% of all cervical cancer cases can be linked directly to infections with high-risk HPV. And the link between a viral infection and the cancer is that HPV has viral proteins, specifically E6 and E7, that bind to and disable or degrade two tumor suppressor genes, P53 and the retinoblastoma tumor suppressor gene. And by doing this, disables the mechanisms that are in charge of DNA damage surveillance and the brakes on the cell cycle in this case. So the effects of the virus on the tumor suppressor genes will manifest as increased proliferation and increased genetic instability in these cells. With increased genetic instability, the epithelial cells in the cervix accumulate more and more mutations. And it is a stepwise progression that can manifest at the histopathology level in these lesions shown here. So the picture to your left is showing us the normal cervical squamous epithelium. The three slides after that are presenting what we call precancerous or pre-malignant lesions. They're also abbreviated as CIN for cervical intraepithelial neoplasm. And the reason they are numbered 1 to 3, they are representing increasing level of atypia at the cell level and at the architectural level of the tissues. Pathologists call these atypical features dysplasia. So while CIN1 will display mild dysplasia, CIN2 has moderate dysplasia, and CIN3 has severe dysplasia. And in CIN3, the dysplasia involves all the layers. And in fact, it overlaps with another designation that we call carcinoma in situ. So at this level, there is high potential of progressing into invasive carcinoma. The only reason we don't call it invasive at this point is that the malignant cells have not broken through the basement membrane yet. Now, the last picture here to the right is showing us an invasive carcinoma. At this level, it's microinvasion, as we see a few cancer cells breaking through the basement membrane. Now, the outcome from these pre-malignant lesions could be very different. So while most or the majority of CIN1 lesions tend to regress in time, and only a small percentage of them will progress to CIN2 and CIN3 and beyond. However, once we reach CIN3, there is a real possibility of progression into cancer, and it is estimated to be about 10 to 20%. So because of this difference in potential between CIN1 on one side and CIN2 and 3 on the other side, the classifications was simplified further by calling CIN1 lesion low-grade squamous intraepithelial lesion, or L-cell, and combining CIN2 and 3 into high-grade lesions, or H-cell. And this coordinates with also a two-tier clinical decision. So while the course of action for the low-grade lesions is just to monitor them, The high-grade lesions require surgical removal. In the United States, approximately 13,000 cases of the invasive carcinoma is diagnosed every year. Compare that to about 1 million of the precancerous lesions. And the reason behind this is the successful application of a screening tool called the PAP test, named after a pathologist, Dr. Papanicolaou. The application for the PAP test for the last few decades has reduced mortality from cervical cancer by some estimates by about fourfold. And in this test, the pathologist or cytologist is looking for a few surface cells that are shed by the cervix of the uterus. And this is how they look like. So panel A is showing us the normal superficial squamous epithelial cells of the cervix. As we move on to panel B, then C and D, we have all the intraepithelial premalignant lesions from SIN1 to SIN3. And notice the increasing level of atypia combined with increased nucleus to cytoplasm ratio, reflecting perhaps the loss of differentiation as we go through the progression of the premalignant lesions. Although the PAP test has been successful as a screening tool, it has its own shortcomings. For once, in the 50 million women that undergo the screening every year, about 2 to 3 million of them will be referred for further evaluation, or what we call ASCUS, atypical squamous cells of undetermined significance. Moreover, the PAP test suffers from inter-observer variability, so it is a subjective test, which will lead to poor sensitivity and specificity. And just as a reminder, so when we are talking about a cancer test sensitivity, we refer to the fact that a test that is 100% sensitive will be able to diagnose all patients with cancer as such. While a cancer test that has poorer sensitivity will allow some patients to go undetected, and that's what we call false negative. And obviously these patients now have missed opportunities to diagnose their cancer and treat it. So they also live with the false sense of security. While if a cancer test is not 100% specific, it will allow people who are disease-free to be diagnosed as having the disease, or what we call false positive. And that is bad in a different way. That will lead to diagnosis of cancer in patients who do not have the cancer, and will be followed up probably by unnecessary, costly, and invasive procedures. Not to mention the emotional toll on the patient. So then the goal of this study is to identify molecular markers, specifically protein markers, that will help us identify the different stages of cervical cancer progression. So we started by collecting 10 samples from patients who have the high-grade premalignant lesions, and we also collected 10 normal samples from the same patients. Separately, we obtained 10 biopsies from patients who have the full-blown invasive squamous cell carcinoma. And the experimental design of this project was to take the tissue biopsies, apply laser capture microdissection to enrich for the phenotype of interest, then extract the proteome from all these samples, separate all the proteins in it into two-dimensional gel electrophoresis combined with fluorescent probes. That will allow differential analysis that is computer assisted and combined with statistical methods. That will generate a list of potential biomarkers that subsequently will be identified using mass spectrometry and bioinformatics. So I will walk you through all these steps, specifically the logic behind the experimental design. So we all know that tumors are complex. In addition to having malignant cells, they also, within the tumor tissue, you will find mesenchymal cells like fibroblasts, endothelial cells of the blood vessels, inflammatory and immune cells. So then we needed a way to be able to isolate cancer cells from the rest of the cell types. And for that, we used a technique called laser capture microdissection, which will allow us in real time to look at tissue samples and isolate the cancer cells by lifting them onto a plastic cap. So here in this slide, I'm showing you real samples that we applied laser capture microdissection to. So in the top panel, we are looking at the normal epithelium of the cervix. And in the first picture, you see the full tissue. And in the last one, you see the one lifted onto the cap. And similarly, the bottom panel is showing us cancer sample. So if we focus on what we isolated on the plastic cap, we can see that we enriched for the phenotype of interest. Meaning, in this case, we isolated the epithelial tissues, whether they are normal or cancerous, and we left behind the connective tissue or stroma. Now, if we take the tissue that was collected on the plastic cap and lyse these cells to extract all the proteins in them, we'll be able then to separate all the thousands of proteins coming from each cell type onto two-dimensional gel electrophoresis, which utilizes separation by charge in the first dimension combined with separation by size in the second dimension. Moreover, we can utilize fluorescent probes in what's called differential in-gel electrophoresis, or DIGE. And in this case, the two compared samples will be labeled separately with two different fluorescent probes, then combined together and separated on the same gel. For instance, if we are comparing normal cervical epithelium to invasive carcinoma, we will label each protein sample with a different fluorescent side-dye. Together, separate them on the dye gel, and then we'll be able to scan for each one of the fluorescent probes separately. Then use computer-assisted analysis to gain information about the relative abundance of each protein spot in the two compared samples. So here I will walk you through the story of one of these spots on the dye gel. This spot happened to have number 667. And And what we notice about it, that it tends to have a very consistent trend. So while in the normal cervical epithelium, it has a considerable level of expression, that level of expression is downregulated significantly in the pre-malignant lesions by about 5-fold. It is downregulated further as we go into the invasive carcinoma, and the difference between the normal tissues and the carcinoma samples was about 10-fold. And this trend was consistent amongst all the 10 collected biopsies for each group. So the mission then is to identify the protein that is in this spot. So for that, first we precisely excise the spot of interest using a robotic arm. Then digest the protein inside the gel plug using trypsin. That will generate tryptic peptides that can be measured using mass spectrometry. The resulting pattern is known as peptide mass fingerprint. And using bioinformatics tools, we'll be able to compare or match the peptide mass fingerprint resulting from this protein spot to a theoretical peptide mass fingerprint in the database that is theoretically based on the genome database. And by doing this, we identify the protein in this spot.
So here is the peptide mass fingerprint resulting from spot number 667. When used in a protein database search, it gave a clear match on a protein named corneolin. And a similarity score was high. This is the number 220 here. According to the algorithm used in the match, scores over 64 in this case will be significant match. The e-value refers to the probability that there is a chance there is another protein match that has similar or greater similarity score than corneolin. But as you can see, this number is very, very small. So at this point, this gives us confidence that there was only one protein in the spot, and that is corneolin. So at that point, not much was known about corneolin except that it is a biomarker for late epidermal differentiation in the stratified squamous epithelium of the epidermis. And there was at least one study showing decrease or loss of expression for corneolin in esophageal cancer. So at this point, we want to take a protein marker that is identified by de novo discovery and transform it to where it can be used in a routine clinical pathology lab. And these labs traditionally have immunohistochemistry ability. So with the specific antibody against corneolin, we can go back and stain the biopsies for corneolin. And the trend we observed with the 2D gel was preserved in immunohistochemistry. So as you can see, going from left to right, the normal epithelium of the cervix has abundance of corneolin, mostly in the upper layers of the epithelium. And there is down regulation in the pre-malignant lesions, the edge cell, and almost loss of expression in the invasive carcinoma. Now, if we were to extend this discovery and find out if corneolin can also be used as a prognostic marker, we went back and acquired tissue microarray that have cervical cancer and pre-malignant lesions in it and all its variation. For instance, an important histopathological parameter is known as histopathological grade. And as we go from grade 1 to grade 3, there is loss of differentiation, which normally is associated with increase in the aggressiveness of that cancer. Now, when we stained all these tissue microarrays for cornealin, we observed that cornealin tends to be more downregulated in the high grades of 2 and 3. Thus, that makes it a prognostic marker in addition to being a diagnostic marker. In addition to cornealin, we also identified 22 potential markers from the 2D gel experiment. And we envisioned that creating a panel of the most promising markers can potentially augment the predictive power of the histopathological examination of cervical cancer tissues, but also the pre-malignant and normal tissues. Interestingly enough, when we did a basic science experiment taking keratinocytes that were immortalized by the human papillomavirus, a lot of these markers also hold true, meaning they are also upregulated or downregulated accordingly in the immortalized cells. Here I have shown you a proteomics approach to identify novel biomarkers for cancer. However, proteomics can be complemented nicely by other omics techniques with the goal of stratifying patients that seemingly have the same disease or the same cancer into subgroups. So we call this molecular profiling. And it could result in prognostic markers, like I showed you for cornealin, for example. It could uncover predictive markers for the sensitivity to a certain cancer treatment or even resistance to a treatment. They might also predict adverse events in certain patients. So by stratifying the patients into subgroups, we can now tailor specific targeted therapy for each group of patients, thus maximizing the cure rate and survival. All this is part of the emerging field of precision medicine oncology. Thank you for tuning in, and if you have any question, please forward them my way.